So let's go on to the next case quickly. The next case here is that of a gentleman here that has some, yes, a middle-aged patient with some swelling in the canine fossa area and the infraorbital area on the right side. And you did your clinical testing here, obviously.
I'm always securing myself with pictures. It's not just to demonstrate the case, it's just to see.
Well, it's great documentation. That's really a critical thing, to have good documentation. And the key is to, not look at an X-ray and see what tooth has a vertical lesion, but do your full testing to do all your required steps.
It's like
to get a systematic approach.
A 3D examination.
Exactly. It's fully encompassing of all the potentials here. So, but I can see what's special about this case. This tooth is so long, it doesn't even fit on the vertical frame of the X-ray. You've taken one from one angle, one from the other to see, to catch
X-rays,
a little bit of it.
See the full length of the tooth.
So let's see, how did you manage? So first of all, again, as usual, disinfection, proper isolation. I really like the fact that you use Opaldam as well here, and that gives you a nice secondary isolation. And here you've done your axis preparation, and originally found the pulp horn and enlarged it adequately in cases that are this long.
It's not bleeding, it's necrosis.
Yeah, it's necrotic, obviously, here. So then you used the very nice trick that you were showing me. And that is that you basically went on there and since your files, your 31 millimeter files were not long enough for this, so you've gone all the way down to 30 millimeters. Actually, your apex locator was showing that you're still not at the apex, so you kind of needed more length. And you broke the handle off of your 31 millimeter, the plastic handle, you removed it.
Yes, I gained 5 millimeter more.
So this is actually the final working length, which is about 35 millimeters here, right? Sure. So you decided to file it using your hemostat. That's again another great idea. So I can see here then that you decided to go on and get innovative here with your paper point as well to dry a canal that you've already irrigated with such a long instrumentation, and you've taken your rotary file and you've threaded it through the back of the paper point.
That's right. I just wanted to reach the apex part, the apical part, the apical 1/3, sorry, and to dry it there, and then to fill it with the BC sealer by using, again, I need to do the same with the gutta percha.
Yeah. Terrific. That's a great idea. And you did the same thing with the gutta percha. Obviously, some of these gutta perchas, they don't get long enough for these kinds of cases. And I've had the same problem in the past with canines, especially. So this is another good trick of cutting the back of it. You create a flat, the end of it, you create a flat little area. Now you thread your rotary file into it. And then you disinfect it also in hypochlorite, which is the right thing to do. Your gutta percha, most of the gutta percha that people get is not sterile, so it has to be kind of disinfected prior to obturation or prior to placement. Because when you have gutta percha in a box that's sitting there for a long time, it can actually gather mold. And I believe that that you can end up having candida or other things that could grow on this stuff later on and cause problems. So it's important to disinfect your gutta percha. This is you're doing it this way. So here is the thing that when you showed me this, I was like, well, wait a minute, this is going to end up getting a little dangerous because you have a very long root, and we talk about the basic obturation technique versus the advanced. The advanced is injection directly. The basic is placing your sealer on a file and putting it down. We teach we teach the placement on a file because it's a little bit safer. But you having a microscope and so on, you had decided to go in and inject directly into the tooth. You've taken that nozzle pretty far down.
Because it's long too.
I agree, but you just so that's the thing. It's just only if you have experience and you see what you're doing. That's the key.
And you need a microscope.
Definitely, you definitely need it
to see what you're doing.
That's the thing. The scope is needed if you're going to inject directly. If you don't have a scope, forget about putting direct injection.
Never.
Go to the the technique of coating your master file and go in there. So here you've done that, and then you put the cone down. You cemented the cone.
I removed the excess by file.
Okay.
Just to not overfill the
exactly.
Tooth. Great. Then I insert the master cone.
The master.
Okay. If you can see in the one in the angle here, it's the gutta percha is in the middle, and I have lasered the sealer.
Yeah.
Okay. So I didn't want to interrupt the sealer and to direct restore the tooth. So I put my Teflon there and GI and send the patient home. At least I need 4 hours for complete sitting of the BC sealer.
Yeah.
So I will not I will just send the patient home. He'll come on the second day. I will do my final filling there. Final restoration.
So you decided to do this in the second visit to restore the access. For those of you who are not familiar with the use of Teflon here, Teflon you can get from Home Depot basically as strips that you use in plumbing. And what you could do is you could cut it down into little pieces and autoclave it, or as like Saif was saying, is what he does is he uses hypochlorite for it. But either way, the idea is the same thing. Instead of using cotton, you can use Teflon. And Teflon is very helpful in the sense that nothing sticks to it, there are no fibers, and it's clean. And so that's another option for using Teflon versus cotton pellets in these cases. So this patient came back, and then you restored it. And this is the second visit they came back.
Yeah. If you go back to the first picture, you will see that he had a +3 in this tooth.
Yeah.
Okay. Distally filling.
But in my opinion, you should always replace the old fillings. If you have a tooth that has gone necrotic and it has a filling, the question is, why did it go necrotic? The main reason is because the old filling leaked. So if you just do the endo, not replace the old filling, you're not addressing the source of the original necrosis of the pulp. So it's very important to replace the old filling.
And it's already 10 years old, this filling.
Yeah.
And discolored, and maybe debonding there or something like this. So
there has to be. I mean, that's why the pulp died.
Yeah.
This is one of the things that my patients oftentimes ask is, when they have an old crown, they come back and they say that, there's necrosis of the pulp right now, the pulp died. So when I tell them that they also need to replace the crown, they say, well, why should I need to replace the crown? The answer is that, why did the pulp die after 10 years of this crown? The reason the pulp died, also, where did the bacteria come from? The bacteria came from leakage from around the crown. Just because the crown is intact physically, that you can see it, it doesn't mean that that gap is as tight to bacteria anymore. There's been leakage. That's what killed the pulp, and that's why by just doing a root canal, you're not addressing the source of the leakage, which is the leakage, the micro leakage around the crown. So in those cases, it's always recommended to replace the crown as well. So this is a great case, and I can see the turnout. This is the pre and the post, and I think you did a wonderful job taking care of this tooth. This is the final fill, and you can see that it's filled all the way to the end. You have a little bit of a puff as well, probably because you injected directly to the tooth. but the results were good. Yeah, of course. And the patient was apparently very happy. The swelling and everything went away. There was no postoperative pain with the puff, right? No. Yeah. So this is exactly the kind of stuff you can expect. So you also have a couple more cases that you've done, and actually we don't want to make this tutorial too long. So why don't we come back for a second?